I think we'll go ahead and get started. Thank you all for joining us today. I think this is going to be a really great roundtable. I'm Tami Garcia. I'm the president and CEO of Prevent Blindness Wisconsin. I am a woman in my 50s with blonde hair, wearing glasses, and a blue and white striped dress. Also the mother of a young boy who 25 years ago was vision screened, and I'm thankful that I did not have to face any of these barriers that we're going to hear about today. Our session today is Why the Eye? Reimagining how we engage communities from identification into care, children and adults. I have an excellent panel today that's going to answer some great questions for all of you. So I'm going to start with introducing the panel. First on the list is Verian Wedeking. He is the program director for OHSU KCI Institute Community Outreach. We have Mayhoua. Moua is the executive director at the Milwaukee Consortium for Hmong Health Incorporated. We have Dr. Antwi-Adjei is the Vision Science Graduate Program Trainee at the University of Alabama at Birmingham School of Optometry. And finally, Mercedes Hernández is the Director of Child and Family Health at the East Coast Migrant Head Start Project. So welcome all of you. I'm excited to be a part of this discussion. And so just have a few housekeeping things for the folks on the webinar. This roundtable will be recorded and will be on the Prevent Blindness website. And we will also be taking some questions. If you'd like to put them all in the Q&A, we'll try and get to those at the end of the session. But we also have some great questions already prepared for the panelists. So without further ado, let's get going, folks. So this question actually goes to all of you. Could you take a few minutes to share some information with us about your work and why the eye is so important for the populations that benefit from your services? So I will just go in order. Verian, I'll start with you.
Sure, thank you. Thank you so much for the opportunity to be here and participate in this panel. My name is Verian Wedeking, and I'm a white male in my mid-40s, and I'm wearing a plaid shirt and I have short brown hair. My pronouns are he and him. I wrote this a little bit earlier, and I was laughing this morning because I typically wear plaid. I don't know if I can blame it because I'm from the Pacific Northwest, but that's what I'll go with. But I'm the program director here for the KCI Community Outreach Program, which we're based out of Portland, Oregon, here at Oregon Health and Science University. And we provide vision screening services and support across the state in partnership with over 35 community-based organizations. And we support them not only through our mobile clinical outreach, but we also have a telehealth, telehealth screening program. And we also train community health workers and other community health advocates as vision health navigators, all in support of Casey's mission to help eliminate preventable blindness in Oregon.
Thank you so much. Mayhoua, let's jump to you.
Hello, everyone. My name is Mayhoua Moua, and I'm the executive director and co-founder of the Milwaukee Consortium for Hmong Health in Milwaukee, Wisconsin. I am a Hmong woman or Asian, and I have a round moon face from the medications that I take for my leukemia for the past year and a half. I have very short, regrowing light brown fuzzy hair. Normally I wear glasses, and I took my glasses off for this conference. And so without glasses, I wear my light purple top with a tan sweater. I'm a mother of 3 young adults, and I live here in Milwaukee, Wisconsin. And at the Milwaukee Consortium for Hmong Health, what we do is that we are a small nonprofit organization. We train community health workers from different ethnic languages that we serve, especially from the Southeast Asian community that are immigrants and refugees to this country. What we do is we call our clients and ask for referrals. We contact clinics, churches, temples, and organizations that serve our population. And we do outreach and education to the community to let them know that we are here to help them with any assistance that they need, whether it's a doctor's appointment or getting health insurance or other social services that are barriers to them accessing health care because they have to take care of their financial stuff first. We work with individuals, we work with small groups, we work with large groups. We work with health organizations to make sure that we have quality connections for our people. And our partnership with Prevent Blindness Wisconsin is to make sure that our people are also being able to access vision screening and have access to eye exams if they don't have eye health or vision insurance. And we've been working with Prevent Blindness Wisconsin since 2018, I believe. So it's been a pretty long partnership that we have, and it's very important to us because many of our Southeast Asian refugees come from very rural parts of their countries where they have not have exposures to corrective lenses. And so, they take it for granted that, losing their visions as they grow older is a given thing. And when we started educating them and getting them into Prevent Blindness's programs, they were very, very happy because now they can get eyeglasses and can see better. And so, we have a lot of good stories that we, that are sharing with us, and we are sharing with Prevent Blindness Wisconsin. And, we hope to continue this partnership. So thank you.
Thank you, Mayhoua. We're very thankful for the partnership, and you look lovely today, so it's good to see you. Next up, I'll say, Dr. Ellen, let's jump to you.
Hi, everyone. So I am Ellen Antwi-Adjei, and I'm from Ghana. Today, I am wearing a plain yellow with a brown blazer, and I'm a dark African lady with a braided long hair tied at the back. And Ellen, I'm talking to you from my office in Birmingham, and it is an office full of books and tools, but I have a blurred background for now. And I come from Ghana, as I have said, and I'm here to do a PhD in vision science. So I'm in a School of Optometry, vision science graduate program, and it's at Birmingham. And my study, I'm part of a study, is an ongoing study by the CDC, and it is on screening and intervention for glaucoma and eye health through telemedicine. And the main idea is to find how we can get to people in underserved communities. People here in the rural parts of Alabama, there are a lot of underserved communities, and we call them underserved communities because, one, there are no specialist care around that area, and two, there's less transportation, and three, they don't even have enough education on eye health. So how do we get to these people? And we know that people in these underserved communities also have most of the at-risk conditions when it comes to eye care. For instance, if you take glaucoma, there's a type of glaucoma we call the open angle glaucoma. And that is very prevalent in the African American or the Blacks. And per research, we have realized that 50% of people living in rural Alabama, that is mostly the places we call the Black Belt part of Alabama, most of the 50% of these people are Black Americans or African Americans. And therefore, we stand a higher risk of having glaucoma. Also, these places have higher number of people who are aged. And old age is a risk factor for most eye conditions. And another thing about these places is that because they don't have enough or adequate specialist care, most people living in these areas have no idea or less idea about why they should go to an eye doctor and why they are suffering from particular signs or symptoms and what can be done. They don't even know the available treatments out there. And therefore, people are just living there with conditions that can easily be remedied. And so my main research is to get to these people through telemedicine. And the telemedicine we are doing is the type that we are focusing on people who are active members of what we call the federally qualified health centers. Federally qualified health centers are subsidized health centers in both rural and urban parts of most states in America. And what they do is, it is per everybody's ability to pay. So nobody is sidelined because of poverty. Everybody has the same access so far as you are an active member of this FQHC. So these are the people we are partnering with to find how effective this telemedicine can can we be able to get to a greater number of people through telemedicine? Because the idea is that visual impairment and blindness is on the increase. And therefore, we need to bridge the gap. If people are not coming to the eye clinics, eye centers, eye hospitals, how do we get the eye care to them without compromising on good eye health? So that's all what my study is about, finding out how effective telemedicine. And we all know that with the COVID that just happened in 2020, there's the agency for telemedicine. We have to bridge the gap. If we don't bridge this gap, there are going to be a lot of people who are going to have visual impairment, visual disability, because they don't get access to eye care. And telemedicine is the way out. And how effective that telemedicine is what the study is all about. And it's about a CDC-funded study and knowing how best this telemedicine can be used to improve on the lives of people in underserved communities. How do we get to them without them staying all this while with impairment that can be easily remedied? Thank you.
Thank you, Dr. Ellen. Mercedes, you want to share a little bit about why the eye for you?
Sure. Good afternoon. My name is Mercedes Hernández. I am a white Latina woman in my early 50s with medium length black hair. I am wearing glasses and a light blue blouse with black polka dots. I am the director of Child and Family Health for East Coast Migrant Head Start Project. And East Coast is a nonprofit organization that receives federal funds to provide early childhood education services for families of agricultural workers. We prepare children for success by providing holistic, high-quality early education services in a nurturing, culturally sensitive environment. We also advocate for children and families in other areas of needs, such as health. We serve about 3,000 children in 48 educational campuses in 10 states. Those states include Florida, Alabama, Georgia, South Carolina, North Carolina, Virginia, Pennsylvania, New Jersey, Indiana, and Oklahoma. And why vision? Well, 0 to 5 year, the period of 0 to 5 years of age is a critical developmental period. Health problems at this stage can have long-lasting adverse effects if not treated on time. So we ensure children are healthy and ready to learn, which includes making sure they have been screened for vision problems, among other screenings that we do. We work with community partners to conduct vision screenings and provide services such as glasses when needed. We also conduct screenings ourselves using instrument-based screenings. We are able to use federal Head Start federal funds to pay for vision services when the child does not qualify for health insurance. And this is very important because agricultural workers in particular, we focus on migrant families, agricultural workers that migrate from Florida upstream all the way to Pennsylvania, Indiana, or Oklahoma, working in agriculture. So they might be a few months in Florida, a few months in South Carolina, and so on, which means, two things. We might have children that qualify for health insurance, such as Medicaid, but they have Medicaid in Florida, but as they are migrating upstream, they don't have health insurance in the other states where they are, their families are working at the time. So we serve a large population of children who don't have insurance. And we also have a percentage of children that do not qualify for health insurance. So for these, when we are serving children in what we call upstream states, they might not have health insurance. So we can use Head Start funds to ensure that they have the services that they need, that they have glasses, for example, to make sure that they see well. And we are the payer of last resort. So that means that when the child doesn't have health insurance, we look for other means. We work with community partners such as, Prevent Blindness, VSP, vision vouchers, Lions clubs and other organizations in our community to try to obtain services or donations for that service. And when we cannot find any other means, that's when we can use our funds to provide services to farm worker children. I'm very happy to be here today and talk and be here today with all of you. Just wanted to mention many of the barriers that my colleagues here have mentioned, because our locations are mostly rural. Many of the barriers are very similar in terms of access to vision care, in addition to not having health insurance.
Thank you all for sharing a little bit about all that you do, and thank you for all that you do for vision. It's really nice to have this panel to talk with today, and thank you for taking the time today. So my first question is, social determinants of health are important factors to take into consideration when connecting people to care. Verian, I'm going to throw it to you first. Can you explain what social determinants of health are and share how you have used community health workers to overcome factors around social determinants of health?
Yeah, happy to. And for this, I'm going to defer to the World Health Organization's definition, just for clarity's sake. But social determinants of health are the non-medical factors that influence the health outcomes of individuals. These are conditions in which people are born, work, live, and age in, and a wider set of forces and systems shaping those conditions of daily life. Those include our economic policies and systems, developmental agendas, social norms, social policies, climate change, racism, and political systems all impact social determinants of health. So one thing that we quickly realized within our program, for the first 8 years of our program, we were primarily centered around our mobile clinical outreach. So we worked with local community partners to identify adults who experience access barriers to vision care. And then those community agencies schedule the individuals, and then we get the privilege of coming in and providing that initial exam with the hope that through a definitive diagnosis, our community partners can connect those individuals to local care. Part of the structure of our program for the KC Outreach program is that we're donor funded. So we actually don't charge for that initial exam. That also prohibits us from directly referring back to our institution. That would be a violation of the Stark Law or CMS inducement. So it really does support that community-based service model that we work in, that our community partners, one, identify those individuals who need the service, understanding that they know their community better than we do. We do provide service across the state of Oregon, so both here in the metro area, in Portland and Salem, and throughout rural Oregon. So while we know the community well, we don't know them as well as our community partners and individual barriers. So one thing that we noticed within the first 7-8 years of our program was, while we were able to do the initial exam, we weren't really quite sure if individuals that were diagnosed with something requiring follow-up care were getting connected to care. So that's what led us to developing this community, the Vision Health Navigator training. Initially, we focused this on community health workers, just recognizing that a lot of the individuals that we were working with from our community partner agencies were CHWs. We quickly expanded that to anybody who's a health advocate, because really it's about knowing the individual, knowing the community, knowing the resources, and empowering individuals to understand a little bit more about eye disease, eye anatomy. So really focusing on raising the vision health literacy of those community health workers so they could be better advocates in both identifying people who may need an eye exam and connecting those people, those local resources. So really our hope with the CHWs is that these individuals are part of the community, they're from the community, that they could act as liaisons to overcome some of these barriers that individuals face, whether that's language, transportation, food insecurity. All of these play into an individual's ability to follow through and get connected to care. You know, one story that we have is one of the first individuals we trained as a community health worker. When she was a child, she was screened and indicated that she needed an eye exam, but she was in kindergarten at that time and actually ended up interpreting her own exam because her parents only spoke Spanish. And that made her obviously feel very uncomfortable. But as she grew up and went through her career, she was very adamant about going through this training in hopes that no one else would have to do that type of translation services for their own medical care. So by training local individuals as community health workers, we hope that they can help overcome some of these barriers people face since they know their community best. And I know, Mercedes, you've got some insight into this too, so I'll kick it over to you.
Well, thank you for that. But yes, we have, I started talking about the barrier of lack of health insurance being one. We have staff at the center level that we call family and health coordinators, and they do similar work than the community health workers in a sense. They are the staff within our centers that interact mostly with those partners, those community partners. We work a lot with the federally qualified community health centers and migrant health centers. They are one of our main partners in providing health services in general. It is fantastic in the areas where we can partner with them. Additional barriers include, mobility. We have to think about the barriers that farm workers face themselves, and which makes hard for parents to bring their children to doctors. Those barriers being lack of transportation, time. Farm workers don't get paid time off, and they're in that community to work, and they work sometimes from sun up to sundown. And the hours when services are available are not convenient for them. So some of the things that we have done, in particular with community health centers, is having night clinics where the children can come and get health care and get the vision screening, as well as the parents. So these takes, we work on these partnerships and these coordination throughout the year, so we're ready by the time our centers open. Our centers, because like I mentioned, we work with agricultural workers, are not open year round. So they're open in some instances only for 2 months out of the year. So this requires a lot of planning and coordination. So by the time we open our doors, we have those services coming, and oftentimes coming to our campuses. So then parents don't have to be concerned about transportation, or they can be transported to one location, or we have block-off exams. Another thing that is particular to migrant communities, as I mentioned, a group or percentage of our children or families are immigrants, is anti-immigrant sentiments. For example, we have centers in Florida, and the current laws in Florida present an additional challenge. We have some centers that are located in the border of Georgia, for example, and these new laws make it a felony to transport an undocumented person across or into the state. And sometimes the center is right on the border, our provider is in Georgia, or the families live in Georgia and our provider is in Florida. So just seeking healthcare and following up on these vision care needs, it's a huge risk for families. So we provide transportation, or we bring the services to our campuses, and through these family and health coordinators, we coordinate those services, and we help families navigate through the barriers that they may face.
That's excellent work for on both of your parts. And you actually just answered the next question, Mercedes, but Dr. Ellen, I'm going to throw it to you then to share your piece of it. Can you give us an example of a barrier in the population with whom you work? And then how have you overcome that barrier to get individuals from identification of possible vision problems to care through examination, diagnosis, and treatment? And I think, Mercedes, you just explained your population beautifully. So Dr. Ellen, I'll let you take this one.
Thank you so much. So one of the people in underserved, as I said from the beginning, people who are in underserved areas have a lot of barriers. And one of them is inadequate knowledge about eye conditions. the risk factors, the diagnosis, the available treatment. And also they don't have access to the specialist care. So one of the things we do through the telemedicine, so telemedicine, what we do with the federally qualified health centers, we have the setups in all of them. And the setup is just like the way when you go to the main eye hospitals, we have all the instruments. So we do visual acuity, we do the eye pressures, we do visual fields. And the visual fields, there are so many, we use different types because the idea is that we need to overcome the challenges that comes with telemedicine. We also use the OCT. The OCT gives us detailed functioning of the layers of the back of the eye. And also we do the fundus photos. And all these messages or all this information, when we gather them at the centers, they are uploaded onto a server. Then the specialists at the main eye hospitals will offload or download them and now go through and come up with their diagnosis and the management regime. And what happens is after the management is reached, the information is sent back to the primary provider and also to the patient themselves. Because we believe that as researchers, we cannot, if people understand, if individuals understand their conditions, it's always better for them to own up because they know what it is and what they are going through. So the main thing is, one, through the telemedicine that we do, the initial stage before we do the various eye tests, we do education. And first of all, there's a survey that we give to them to know their knowledge about eye health. So we will not tell them anything, we just give them the survey. Ask them questions about glaucoma. Is there any need to go to your eye doctor? Why do you have to go to your eye doctor? So we ask all these questions. Then the participants will give us their ideas about that. After that, we show them a video. And the video it talks about the eye from the anterior side, from the front of the eye to the back of the eye, describing what you have to see in a good, like a normal eye. And after we show them the video, we ask them the same questions we asked before again, just to know their knowledge base. Because the main idea is that we want to get rid or reduce amount of ignorance or less education when it comes to eye care. So after showing you the video, did you understand? Do you have any questions? So that is one thing that is very interesting about this study, because people come up with the questions that they have. And you can see that the questions that they have, the kind of questions they always ask, infer on why they don't go for eye checkup. Because they don't see why they should go for an eye checkup when they don't have any itching, they don't have any pain, they don't have any redness. Why do you have to go for an eye checkup? So when we show them the video and give them that education as part of the study, and the questions that come after, it gives us the opportunity to educate them more about the eye. And then as we take them through every section of the comprehensive eye care, we explain what every instrument does and the outcome of each instrument. And at the end, the report is also gotten back to them. And because they are having their eye care at the same place that they meet their primary provider, it is also very convenient for them because it's like a link between them and their main provider. And one thing about it is that throughout this study that we have done, the number so far we have analyzed 500 participants, and the information we are having from it and the data we are getting from it is very encouraging. It shows how much diseases are out there in the underserved areas. And that if we all want the visual impairment or the visual disability that is on the ascendancy to come down, which is my passion as an optometrist and as a public health specialist. All the years I sit in the clinic and wait for individuals to walk into the clinic, then I treat them. But they walk into the clinic at stages where sometimes not much can be done. And therefore, if these individuals understood these conditions before, they could have come in for us to help at better than the stages that they do come in. So this telemedicine is a good way. And as I said initially, the COVID gave us a wake-up call that we all need to come, all hands need to come on deck, because people in these underserved areas need eye health. They need eye care. And eye care, as a public health specialist, I don't think eye care should stand as a vertical thing. It needs to be horizontal. It needs to be incorporated into the normal health that we do. So if we have the FQHCs having eye health in their centers, people go and see their provider, then they have their eye care also attended to. For instance, if you take the rural parts of Alabama, for instance, most people, we know that if you take the United States, Alabama is leading in the prevalence of diabetes. And diabetes, when it is not cared for, leads to diabetic retinopathy of the eye. And diabetic retinopathy is also on the ascendancy. So the whole thing is, if people get to know their conditions early, and that is what the telemedicine is focusing at, early detection, early management. And so we are using this telemedicine as a tool to help people to understand why eye care. Because we have this study so far, we interviewed people, and out of the people, 20% said that they do, out of the 500 participants we have surveyed so far, 20% said they don't have any reason to go to the eye care. And you know, the interesting part is this 20% people who are 20% of the people who are saying they don't have any reason, we did the screening and we realized that some of them have glaucoma, some of them are glaucoma suspects, some of them have ocular hypertension, some of them have age-related macular degeneration. And they are saying they don't have any reason to go for eye care because they lack the necessary knowledge when it comes to eye care. So the telemedicine we have used and we are using as a tool to bridge that gap, as I said initially, because these people need to be heard. They need to know the essence of eye care. And the whole thing about eye care is about routine eye examination. The key about eye care is routine eye examination. It's until you walk in. Glaucoma is asymptomatic. If you don't walk in, there's no way you can be walking on the street and you will say that my eye is itching, therefore this is glaucoma. You need to come in so that we use what we call the opportunistic case study. So opportunistic screening is when you come in with a red eye, we do the necessary comprehensive examination and come and realize that with all these signs, you rather have glaucoma. So we'll treat the red condition and as well educate you on glaucoma and take it from there. So our telemedicine is really breaking that barrier of inadequate knowledge about eye care, and it's also breaking that bridge or that access to specialized eye care, because with the telemedicine, all the images are sent to the specialist and they look at all the images and come up with a diagnosis. So the usual case where we go to the eye hospitals and encounter our eye specialists, this is not it. The telemedicine is rather helping you get access to a specialist where at the normal circumstances you wouldn't have gotten access to, because we have few optometrists, few ophthalmologists. So they can't all be in these underserved communities at the same time. So the telemedicine is breaking that barrier where you can't have access to specialists. Telemedicine is giving us people in these underserved areas, these rural communities, the ability to have access to specialists. And with this study, they can always send messages or send emails to the specialists. It means that they also have access through this telemedicine study. And the outcomes so far, all the surveys we have done, 85% are saying that they are very satisfied with the telemedicine because it is educating them, letting them know their condition at every point in time. So telemedicine is effective and it's also scalable to all other nationwide, to all other FQHCs and similar settings, which is really helping at this moment. Thank you.
If only you were more passionate about it, Dr. Ellen. I don't know where we'd be. We could talk about this for hours, I think. Thank you. That was excellent. And again, what a great way to reach so many people and, you know, be thoughtful of how to get to folks. So Mayhoua, I'm going to go to you. I've had the pleasure of working with Mayhoua for many years, and we've had a lot of lessons learned through our partnership and sort of changed the way we do our work. But my question for you is, could you share the cultural and language considerations that can be put in place to support the Southeast Asian community and accessing eye care?
Thank you, Tami. Thank you for the question. Yes, at the Milwaukee Consortium for Hmong Health, we serve currently 5 different languages from the Southeast Asian refugee population. That includes Hmong, which is my people. And then we have Laotian, we have Burmese, Karenni, Chin, Kachin. And so, you know, and most of us came to this country as refugees at different times, of course. My people, the Hmong community, as well as Laotians and Vietnamese and Cambodians came here back in the 70s after the fall of Vietnam War. And so we came here to escape persecution because of our affiliation with the United States. And so we came with nothing on our back. We have no knowledge. Most of us have no knowledge of Western medicine practice. Some may have some kind of formal education. And then in the early 2000s through 2010, we started seeing new refugees on the streets in Milwaukee, Wisconsin. And so we know they are from Asia because they look very much like us. And so when we start reaching out to them and start learning about them, we learned that they are from Myanmar. So we started to expand our services to include the Myanmar refugees. And so, you know, as we continue to learn about them, we realize, you know, we need to include them in our services as well, because, you know, they are from the same situation as we are from, you know, war-torn countries, very rural parts of their own countries where they have not been exposed to Western medicine practices. Literacy is also a very low in the population, as well as among the Hmong and the Lao as well. And so, you know, a lot of our educational materials have to be visual, you know, more pictures, less writing, a lot of oral communications, spreading the words by word of mouth. You know, having literacy materials is good, but not everything is translatable because, you know, people can't relate to it unless somebody is there to explain it. So, you know, we had to redo a lot of our materials over and over again until we get it down to the very basic. Even now, we still have literatures that we pass out. You know, many of our people don't read or write within in their own native languages as well. So we still have to do a lot of, you know, oral education. We use pictures to provide them with some visuals to understand anatomy, which most of our population don't understand either. And so we have not developed a curriculum specifically to vision health yet. And that's something that Tami and I will have to work on in the near future. But then again, you know, if we do, you know, how do we put that onto words that our people can understand? Because, you know, we lack a lot of vocabularies that, you know, are not translatable into our languages. So it's going to be a lot of explanations. So that's going to be a very tough thing for us to do yet. But I think we might want to start looking at some very basic stuff. But that's how we, you know, that's the population that we work with. And so how do we work with them individually? Well, you know, as I referred to when I did my introduction, we have community health workers from different ethnic communities. You know, we have a Karen community health worker. Well, we now have 2, but one is dedicated to the vision health program. We have 2 Karenni community health workers. We have a Burmese community health worker, and then we have myself. We have yet to hire a Hmong community health worker who can do a better job at outreaching to the community than I am. being administrative and trying to do direct services has been a very tough situation. And then we also need to find another new community health worker from the Lao community, because without having that language person, we've been neglecting languages that we've been serving for a long time, but we can't communicate with. And so then we rely on volunteers to help us with interpretation. So, it's been very hard, but the important thing is that we are making ourselves visible in the community. We attend the community events so that they know that even though we don't have a representation from their ethnic group on our staff, that we still care. And that's the important thing, is making sure that people know that we still care. We will serve them. And for every broken language, English that they can speak with us, we encourage them to try to improve their English by speaking with us in English. And then, we try to use broken English or very basic English with them to get our message across, to make sure that they know that we are there. We are never the interpreters, because we are always their advocates. And so we always made sure that there's always interpreters available at appointments. So that way, when we go in, we can advocate for our clients. That's where we feel it's very important for us. However, we know that with vision health insurance, they don't always have interpreters available. And so sometimes we just have to become the interpreter, but we always make sure that the providers know that we will be their interpreters, but we will also be advocating for our clients, because we're not getting paid by the clinic to provide interpretation. So we have to have that capacity to advocate for our clients, because again, most of our people come from very rural parts of their own countries. They have never been exposed to health care services, and this is very new for them. And so they have to understand, they need to understand, but they won't know how to ask questions because they don't understand these yet. And so we have to play that role for them. And so, being mindful of their background, the language barriers, the cultural barriers, and our American culture. That's something that we have to constantly be mindful of, so that we can better serve the people that we work with.
Thank you. I think all of you have done such an excellent job of, meeting folks where they are, what they need. And it's really exciting to hear this conversation. And I know we're running short on time, but Verian, I'm going to throw this question to you. How do you evaluate your programs and services for their impact?
Yeah, great question. And I think too, not only evaluating your program for impact is looking at what you're doing to give insight into different interventions that you can produce better outcomes for. So initially, we look at not only the number of referrals, classes that we provide. Being a donor-funded program too, we look to make sure that we have a wide representation of community partners that we work with. But we also are now, with our telehealth sites, one of the great things about this is that now we're able to, because actually similar to Ellen, is we've embedded these OCTs, imaging devices, specifically in our FQHC primary care partners. And part of that is so that at that primary care medical home, we can then track the patient's initial diagnosis referral through their primary care medical home to local providers. But I think, oh, sorry, I got off track there. Could you remind me of the question? I'm sorry, I want to make sure I answer that effectively.
How do you evaluate your programs and services?
Yeah, so that's one of the exciting things about our telehealth sites, is that we're actually going to be able to track individual participants that we give an initial screening through into the continuum of care. So that's something we're really excited about. But historically, what we've tracked is the number of referrals we provided, how many classes we provided through our mobile outreach. One great thing about our mobile outreach program, though, and for us really at KCI, it's about combining telehealth with mobile outreach with local care coordination. Independently, I think those all fail. You can screen as much as you want with the OCT, but if you're not addressing low vision through addressing refractive error, that's the majority leading cause of low vision. So with our telehealth sites is that the goal of those sites is that we screen people on a regular basis, just because our mobile unit can't be everywhere all the time. So that increases access. But then if we aren't able to get a an appropriate image, or if that individual does experience barriers to care, then our mobile unit will come out every 4 months to that telehealth site to make sure that we do a definitive exam and or provide as much care as we possibly can. So really working with our community partners on making sure that we don't leave any gaps for individuals. And then also with the community health worker training, one of the resources we have as the VSP gift certificates. So helping people learn, community health workers learn how to do basic acuity screenings, and then actually using the Ohio Prevent Blindness checklist for glaucoma and macular degeneration to see if there are risk factors. And if there are, then getting them into ophthalmology versus optometry care.
That's excellent. Thank you. So for the sake of time, and I think we could have about, again, a 3-hour session to go through all of this, but I'll throw one last question out to all of you and, maybe just a brief snippet on answering, and unfortunately we have to wrap it up. But again, for all of you, what key takeaway around our theme, Why the Eye, do you have for the audience today for getting the individuals and families to care? And Mercedes, I'll kick it off with you.
Our key message is really working with partners and knowing your communities. There is, I would say, there is no one size fits all for everybody. And I think really knowing your partners, knowing the barriers, knowing the interests, knowing the needs, and being flexible in meeting those needs. As I mentioned, we are located in 10 states, and the environment is very different in those states. So in some areas we have pediatricians that are conducting screenings. In some areas we're having a lot of those screenings coming back as the child is uncooperative, and we don't have data on really the health of their vision. In some areas we have these partners, in other areas we have a number of barriers. So I would say just being flexible, creative, and work with your partners in really meeting the specific needs of the populations you're working with.
Thank you. We have about 1 minute. Dr. Allen, I'll throw it to you for your response.
Thank you so much. If I had time, I had a lot of key takeaway messages, but because we don't have time, the main thing is that we have realized out of the 500 participants that we have surveyed so far, half of them had to be referred for follow-up because they had a lot of conditions. And the interesting thing and what is so touching is that out of half of the people that have been referred, almost 80% have actually gone for their follow-up. And this is telling us that when you read literature, previous studies have said that screening is not effective because people do not go for follow-up. But for us to have a telemedicine where 80% have gone for the follow-up and are benefiting, it is telling us that there has to be a new shift. There has to be a new orientation of mind. Policymakers, funders, and sponsors must come in. The way forward is people are ready to go for a follow-up when they know what is actually wrong with them. So the message is, let us all adapt routine eye examination, and the more money must be pounded in because we are ready to go for follow-up. Thank you so much.
No, thank you. That's excellent. So unfortunately, y'all, we ran out of time, but I want to let the audience know that the panelists will all have a session individually afterward, and the links are posted for you if you'd like to go in and spend some time. They have a 30-minute chat room session for you to join in and maybe get some more follow-up questions. But thank you all. What a great conversation. And thank you all for the work that you do.